Hello, everyone, and welcome to this episode of The Forefront, Hypoglycemia Management from Different Practice Perspectives. I'd like to start by saying thank you to Xeris Pharmaceuticals for sponsoring this video. My name is Jody Lavin-Tompkins, and I'm a nurse and certified diabetes care and education specialist and director of accreditation and content development at the Association of Diabetes Care and Education Specialists. Joining me today are Amy Hess-Fischl and Dr. Katie O'Sullivan, both from the Kovler Diabetes Center at the University of Chicago. Amy is an advanced practice dietitian and coordinator for the University of Chicago Kovler Diabetes Center Teen in Transit program, and Dr. O'Sullivan is a board-certified adult and pediatric endocrinologist. Today, we'll be talking about how hypoglycemia treatment protocols have changed in inpatient and outpatient settings due to new formulations of glucagon that are now ready to use. Amy and Dr. O'Sullivan, welcome.
It is such a pleasure to be here.
Thank you for having us.
Sure. Well, I wanted to ask both of you if we could start by you giving our viewers an overview of how you collaborate to promote safe transitions of care from the hospital to the outpatient setting.
Happy to jump in. Yeah, so when an individual with diabetes is in the hospital, our endocrinologists see those individuals with either newly diagnosed or existing diabetes through a referral. Now, really an individualized treatment plan is developed with the inpatient diabetes care and education specialists and the endocrinologists. And then what happens is that when that care is transitioned to the outpatient setting, they are then referred to my fellow diabetes care and education specialists and myself that are within the outpatient setting. And of course, when we think of the 4 critical times for DSMES, this is a perfect opportunity that these individuals are seen for DSMES that are including the key topic areas that kind of go when it comes to severe hypoglycemia as well, and insulin use or sulfonylurea use.
Yeah, as the inpatient physician, we really try to make sure that individuals with diabetes have as much education as possible prior to their discharge home. This education is primarily the basics or the building blocks of diabetes management. We, of course, would like for people to feel confident that they can manage the diabetes at home on their own. But we know we only have so much time to provide education in the hospital, and we count on our outpatient team to provide that additional diabetes education when they establish care with their outpatient provider, reinforcing the lessons that they've already learned inside the hospital. We keep a checklist of the diabetes teaching lessons that are covered when patients are in the hospital, and this checklist is easily accessible by our outpatient team. So the outpatient team has an idea of what the patients have already learned, and they can really continue the diabetes education from where the patient left off in the hospital.
And one other thing that we like to do as well is, because we are so fortunate that our endocrinologists work both inpatient and outpatient, we're collaborating in the outpatient setting because, of course, they're seeing these individuals as well. And so we're able to even see those individuals at the same time as they're coming in to see the endocrinologist too. So there's a lot of communication that's involved in this. And we know that it takes a team on both the inpatient and the outpatient side to make sure that we're truly individualizing the care for these individuals.
So it's really great to hear there's that continuity of care that you've established. And I noticed how both of you emphasize the importance of education. So I want to move on to ask you more about how practice, education, and care have evolved with the availability of ready-to-use glucagon in your respective settings.
We have seen such a tremendous positive experience with the new formulations. And we know that that's really increased the number of prescriptions that have been written since they're far more intuitive to use than the traditional glucagon emergency kits. They're easier to train family caregivers, again, school staff, to be able to just not be so afraid of using something that is a life-saving measure. We know that so many people previously didn't want to use them because they were afraid they were going to do it wrong, or it wasn't going to help and they weren't going to be able to deliver what it was supposed to deliver. So we're also seeing that, glucagon is a standard of care for anyone that's on insulin or orals that cause hypoglycemia. We want to kind of normalize this as something that everyone should be having. Everyone should not be afraid of using this because, again, it is such a safety measure. We also know that alone having glucagon in the newer formulations is increasing the confidence of people with diabetes, and they can use it to really prevent potential 911s. Personally speaking, I think of so many individuals that I work with that live alone, and again, empowering them to be able to say, I can do this. I don't have to be afraid. I don't have to kind of wait until the very last minute or have someone else deliver this for me. This is such an easy thing for me to do if I'm following all of my hypoglycemia kind of checklist of, that last step that I can't have oral carbohydrate, and I can do this very simply and keep myself out of the hospital, keep myself from having some nice looking, first responders, looking over me and when I'm waking up.
Yeah, in the hospital setting, when we see folks with diabetes and they're being ready for discharge, we really try to get these newer preparations of glucagon to have them have prescriptions with them or to get them into the hands of them before they leave the hospital. We know that they're easier to use than the traditional glucagon emergency kits. And our inpatient diabetes care and education specialists are familiar with all of these newer preparations. And so we can directly provide teaching for those individuals with diabetes that need to know how to use these tools to go home and to keep themselves safe.
And then once they come to the outpatient setting, this is for diabetes care and education specialists. When we think of the curriculum from the updated national standards for DSMES, again, this is part of the acute complications. And so this is kind of a solidified piece of having that conversation with every single person that has diabetes, that they need to know how to use this if they're taking medications that are going to lead to hypoglycemia.
Right. So I know that lots of hospitals and even outpatient settings, we all work off some sort of protocols. And so I'm wondering, how have or should treatment protocols change for use of glucagon?
Well, I know, and I know that Dr. O'Sullivan's going to talk about this in much greater detail from the inpatient side, but, working with some of the inpatient educators that I know, we know that it's been kind of an unwritten rule in the pediatric world that regardless of who's coming into that hospital, they're getting a glucagon emergency prescription. Again, it's just part of the checklist. But also, when we're looking at both the adult and the pediatric side, again, they do have kind of protocols of anyone that's on insulin. They're being trained on all of the particular formulations for safety reasons. But again, certainly what we have to really think about, globally, is expanding the advocacy to use it in anyone that's on oral agents as well that cause hypo. We certainly think that insulin is a no-brainer, but we have to acknowledge the fact that there are so many more people with type 2 diabetes that are taking oral medications as well as insulin. And they don't necessarily understand that their risk is just as great as the type 1 world. So again, we really do need to be shouting this message from the rooftops to make sure that people understand that anyone that has a risk for hypoglycemia needs to understand the use of glucagon. Also, when we think of kind of how treatments are kind of changing and protocols are changing, we know that one of the traditional glucagon emergency kits is being discontinued at the end of the year, which does mean that it's opening the door for more of the easier to use kits that are going to, again, like I said, reduce that fear of not doing and preparing correctly. So I think that when we look at kind of protocols across the board, We want to make sure that glucagon is a standard of care for every single person that's at risk for hypoglycemia. We have to also keep in mind that when we look at, over 8 million people that have diabetes that are taking insulin, we're not even talking about orals, and when we look at some of the numbers, less than 700,000 prescriptions have been filled in the previous years. So again, we know that we're really missing the mark. And we know this is a safety issue. Again, we can prevent deaths. We can prevent complications due to severe hypoglycemia. And so it's really clear that we, again, need to make this message very, very clear to people with diabetes, that why they need to be filling these prescriptions and why it's essential that it is a standard of care for all of them.
I totally agree, Amy. And that's astonishing with how few prescriptions for glucagon are filled when there's really a need. So from a physician perspective, just to reiterate, I agree with Amy. Every child with type 1 diabetes, it's an automatic no-brainer. We prescribe glucagon for them from the moment they're diagnosed and keep those prescriptions active. When we mention about our older folks, their patients with type 2 diabetes, I automatically think of glucagon for those who are on more than one insulin injection a day, or those on just one insulin injection a day, or non-insulin medicine that have those risk factors for hypoglycemia. So what are those? So I think about our patients who are especially aging. So those who are older, over 60, I think about those who have decreased kidney function, and those who have conditions that make it difficult to eat regularly, or those who are losing weight or skipping meals. These are all risk factors for hypoglycemia. And it's really important that those patients in particular have a prescription for glucagon.
So it sounds like there needs to be some planning involved in this to get people what they need and to get them to fill those prescriptions. So I want to move next into discussing any obstacles or challenges that we might need to overcome to ensure that people do have that hypoglycemia treatment plan.
So on the inpatient side of things, the diabetes providers are typically the consultants, and we give recommendations to the hospitalist team or the primary care physician about the diabetes supplies and medications that a patient really needs when they go home. So communicating the importance of glucagon from a diabetes perspective, from a diabetes provider perspective to the primary care physician perspective is really important to maintain those communication lines. At our institution, we have a set of diabetes orders that are available for providers to just click for patients when they're being ready to be discharged. So we make sure that they have everything that they need to do to check their blood sugar, their diabetes medications, and then with that, the glucagon and especially the newer preparations of the glucagon. Then, of course, from a provider perspective, we know that some patients are limited in terms of what they can go home with because of what their insurance will cover. And so we have a unique program at our institution where we really do try to get patients their medications in their hands before they leave the door. And so we work closely with our pharmacists and are on top of trying to understand which medications those patients will be affordable for the patient, and if applicable, where we can apply things like copay cards to make those medications more affordable for them. So they're really getting everything that they need to manage their diabetes safely at home.
And thinking about when they come into the outpatient setting, again, that's where the outpatient diabetes care and education specialists reinforce that messaging of everything that has been given to them upon discharge, and then really kind of digging in a little bit more regarding whether they've actually filled that prescription or not. Again, I think that our role is really to identify why, and again, really collaborate closely with the outpatient endocrinologists to make sure that and our outpatient pharmacists as well, to identify if there's something that's going to be a more affordable option. Because again, it usually is sometimes cost itself. But, again, it's really the other issue that we see is really when to use it. and just using it itself. So, I think we all have to be speaking the same language. And we have to also acknowledge the fact that these newer formulations are new. And so it's going to take time for all of the healthcare providers to be comfortable with them. But I think it's all about that repetition of really keep hammering in the messaging is that this glucagon is not a bad thing. Now, again, I'm not saying it's the first thing that I want somebody to use for hypoglycemia, but we need people to understand that this is the safest product to use for severe hypoglycemia, and it's a life-saving product. So we want to really couch that and say that, again, if you've already followed all of your hypoglycemia kind of treatment methods, and you can't get any further, in the oral route, then this is something that needs to be done. Again, so we've exhausted all other options that are going to bring that glucose up. And so certainly when we think of standards of care, again, it's entirely within the realm of reason that someone that lives alone can give it to themselves. So we have to kind of change what we used to say before, kind of unconscious and unresponsive only, meaning someone else is going to be giving this to them. We have to really look at those people that are living alone, or again, the teenager that's out on their own for the first time. Again, we want to empower them to be able to feel confident that they can use these things. We also know that the ready to uses are much easier to use, of course, and they have a greater than a 2-year shelf life. So they're going to be available for a longer period of time. We know that glucagon is not something that we want people to use all the time. It's there if they need it. But again, if they don't need it, that's okay too. So we want to make sure that we're getting them confident and empowered to be able to use this. Also, I would say that for all of you listening, there are some really great resources that are available on the CDCES website. The Hypoglycemia Treatment Planning Roadmap. So again, a really nice step-by-step, and as well as some access and affordability information they have on their access and affordability page as a resource on diabeteseducator.org /affordability.
Well, Amy and Dr. Sullivan, thank you so much for taking the time to join us for this episode of The Forefront and sharing your knowledge and expertise with our audience. For me, as a diabetes care and education specialist, I know how useful this information is for practice. So I'm sure our listeners really appreciate hearing your firsthand experience. We also want to thank our sponsor, Xeris Pharmaceuticals, once more for their generous support of this episode of The Forefront. To learn more about Xeris Pharmaceuticals and their novel formulation technology, visit xerispharma.com. That's XERIS pharma.com. Thanks for tuning in. Check out diabeteseducator.org /forefront for more links to resources from today's episode. Thanks for watching, and please join us again for future episodes.